Top Bed Talk.
I'm Mike Grocott. I'm one of the conference organisers, and it's a pleasure to welcome you back to this session, which is in collaboration with and focused around the work of the Centre for Perioperative Care. And most of the work today is going to be done by Dave, so Dr. Dave Selwyn, Medical Director within the NHS, but also the Director of the Centre for Perioperative Care. So Dave, I'm going to hand over to you. Thanks very much.
Thanks very much, Mike, and hello everyone, and welcome to this session. So the Centre for Perioperative Care has been in existence for just over 3 years or so. It's an initiative that was started before the pandemic, if we can remember that far back, and it's hosted and funded significantly by the Royal College of Anaesthetists. But this isn't an initiative that is all about anaesthesia, about intensive care or any of those aspects. It has a series of what I like to call high-value, high-profile stakeholders on its board, and brings together the voice of surgical members of the team, physician members of the team, nursing members of the operative, and the whole pathway, including GPs and particularly patients. And what we're going to talk over the next 90 minutes or so is perioperative care, who should do what and how. And what I'd really like, we're going to do some presentations first, just to set the scene a bit, but what I'd really like is this to be a conversation, and I'd like it to be a stimulating conversation if we can. So rest assured, we'll try and get some of those questions going. So we're going to start off with the first presentation, and I'm delighted that Laurence Mudford's going to come and give this, to give some of the views about really what the patient should be asking or should be thinking about when they embark on their perioperative care journey. Laurence, would you like to come up and give us that talk?
Thanks very much, Dave. I want to talk about what do and should patients expect from perioperative care. My background is healthcare. I was a dentist for 40 years in the NHS, and then I became a patient. And becoming a patient, as many of you will know, is a very sobering experience when you have a clinical background. I had a cancer that was diagnosed, which fortunately was sorted out within a 6-month period, which was absolutely fantastic. But what I learned was that life can be both simple and life can be incredibly complex. You see, we spend the vast majority of our lives as general public. And then once in a while, when often we don't actually expect it, we get ill or we're diagnosed with something which is going to be quite serious for our lives. We transition from general public to being a patient. And then we start a journey. And we often think of journeys as a start and as a finish. But many of you will realize here that actually it's the bits in between which really make up the whole journey. It makes it either successful or not so successful. It's either appropriate and seamless, or it can be a real difficulty for a patient to actually go through. Now, to be totally honest with you, I actually find the term perioperative care a difficult one to define. And that's mostly because you clinicians out there often change the definition on a regular basis. We all think we know what it means, but we're not actually too sure to put it in writing. Here's my lay version. It goes a little like this. Perioperative care is a term used to describe the care that is given during the entire length of a patient's journey from diagnosis to recovery, with as few cock-ups along the way as you could possibly get. And that's something I've found as I've gone through it. When I describe it to patients and patient-facing organisations and clinicians, I use the analogy that perioperative care, when it's working really well, is like a 400-metre relay race. Many of you will be familiar with that in athletics. We've got the World Athletics Championships coming up. Every person who runs a leg has to be at their best. Their training and preparation has to be superb. But also the supporting people, the physios, the psychologists, the people who get them there on the day have to also be part of that seamless interweaving that athletes actually need to have. They need to know their roles. But the critical part, as many of you will know if you've watched the athletics, is that passing on of the baton. It's the most critical part. If the transfer is successful, then everything seems to work really, really well. But at every stage of that baton being passed on, there's a high risk point where one person has to give something over to somebody else. And everybody has to be on top of their game. And if they're not, there is a disaster. The baton is naturally dropped. And so with the perioperative experience that we have in a patient journey, there may be very successful legs that are run on a regular basis, but it only takes one baton drop to compromise the outcome for the patient. And you've guessed it. We as patients are the baton that can easily be dropped as you go from one part of the journey to another. And the journey is often put into different sections: prehab, hospital, rehab at the very end of it all. But I would argue strongly that this only focuses on the clinical aspect, and actually the clinical aspect of secondary care. And as such, it misses out on a really large part of the journey of what patients do and actually should expect from what they get out of their healthcare. And in fact, it highlights the silos that are available. And they're often unintentional in healthcare. You get GP practices, you get the nursing sections, you get the patients and the families and the carers, all of whom become stakeholders as this baton is passed on. And by silos, what I really mean as a patient for a moment, it's opportunities for the baton, me, the patient, to be dropped. So what do and should patients expect from a holistic and a joined up perioperative care journey? Well, let me give you a couple of examples aligned to the perioperative care journey that a patient would expect. What should they expect? Well, let's start well before we become patients. Because I believe that perioperative care starts with lifestyle choices. And if we're better informed as general public, as future batons, if you like, we're less likely to be dropped. It's as simple as that. Healthier public taking ownership of their healthcare will mean less complex difficulties as you go along. And those lifestyle changes that we expect from our patients really do need to be based on behavioural science and motivational science, not just shocking people into doing something differently for a short time. We should be past the stage where putting fear pictures on a packet of fags is going to actually make a difference in healthcare. That's a bit like bolting the door after the horse has disappeared from the stable. Public and patients need to understand actually the risks and take ownership of their health style choices in a way that they can take that ownership for themselves. And that should go across every bit of the social strata, whether it's ethnic, social, health literacy, geographical, postcode. Whatever the situation is, our public should expect to have the best quality of prevention that they can. Patients should expect this to be the norm rather than the exception. And when you're signed up on a waiting list, or as we like to call it now, a preparation list, and you'll hear much more about that in the panels later on, it gives us the chance to prepare people rather than sitting idly wondering what's going to actually happen to them. Then patients should have sufficient knowledge and understanding of their health conditions when diagnosed, both verbal, electronic, and, good old-fashioned leaflets that are given out to people. Because we want them to be experts in their health condition as they're diagnosed. When I was diagnosed with cancer 5 years ago, I moved from a reasonably competent clinician to what I can only describe as a gibbering wreck of not really understanding what was happening around me. My diagnosis came for something that was asymptomatic. And so when it came, it was a great shock to me. And it's really important to remember what those patients are like at that stage. So for me, it came out of the blue. But what I can remember, and I can't remember much about it, there were two people in the room. One was the consultant who introduced straight away the second person as a Macmillan nurse. It's a great start, isn't it? I automatically knew there was something up. And he said to me, this person is going to take you into the next room in a few moments, and they'll tell you about your cancer diagnosis and what your options are. Right, I've got cancer. That's how I knew I had actual cancer at that particular moment. It was almost like I was at an operational safety list. You know, the ones that you carry out in theatres on a regular basis? This one went, the consultant has told the patient he has cancer. Tick. The patient has been passed over to somebody who's going to pick up the pieces. Tick. We'll just wipe the chair down now because we've had lockdown and we'll move on to the next patient. That was my experience of not really understanding the process I was going through. Thirdly, I think patients should expect more participation in decisions and the choices and the creation of a patient-personal professional relationship that builds. I've been the patient lead for the PRSB shared decision-making standard over the last 2 years, putting together a standard that patients and clinicians can use to make sure that patients are actually given choice at consultations. Patient feedback was essential in that to really bring this standard to life. You see, patients recognize that a structured approach to supporting them in their decision-making is vitally important. That it would help the person's understanding of their diagnosis, their risks, the benefits, and guess what? Not doing an operation, because we know in this room that 14% of patients often say, I wish I'd known all of that before I had the operation, because, do you know, my quality of life is so poor now, I would have actually liked to carry on as I will. I was listening to Hugh's talk earlier about palliative care versus intentionist care. And at end of life, many people would rather, I'm sure, enjoy their last 4 to 6 months without huge intervention, if only they knew the choices that they actually had. This is all about perioperative journey of a patient. And fourthly and finally, patients and public should expect to play an active part in developing post-operative care for themselves. You see, perioperative care should be tailored to patients, and I know we all accept that, but we have difficulty sometimes knowing how to put that into action. They should be there right the way through the process of developing perioperative pathways, and they should also be there for the 360-degree rotation to review and actually refine and implement and make sure it gets embedded at the end of it. And please, can we get rid of these oft-used phrases of co-design and co-production, which to the vast majority of patients, I have to say, are entirely meaningless. I saw this definition on a research paper a couple of weeks ago. Co-design is all about meaningful end-user engagement. Well, thank you very much. I now know what co-design is all about. Let's really try to explore collaboration, where we just get together in a room and we say what's really important to you as an end user or as a patient or as a general public or a carer or a family member. You see, it's not just tapping into individual knowledge and trying to pull something out of a stakeholder engagement. It's about discovering people's unique and collective perspectives about healthcare, their own healthcare, to make sure they're part of a cohesive process to bring clinicians, public and patient together. There are many more examples I could suggest, and I hope this just fleshes out a little about a patient perspective so that we can have a general discussion later on of how that actually works. So let me summarise as I close. Patients should see that what perioperative care looks like when it works well. They should expect to experience better quality healthcare, a general healthier lifestyle, improved shared decision-making, less late cancellations for their operations, and clearer understanding and communication if it does get cancelled and changed. Improved quality, fewer readmissions, less long-term complications, and actually improved quality of life. And you know what? If we do all of that, there are less bruises from the baton being dropped on a regular basis in healthcare. And if those summary statements seem a little bit familiar, well, they should be, because that's what clinicians want as well. It's a way of bringing all of that together, particularly with lockdown and the backlogs that we're dealing with at the moment. And isn't it time that true collaboration between all stakeholders, if I can use that as a general term, especially public and patients, really starts to put the patient firmly back at the centre of healthcare, not just in the UK, but I know right around the world from other people who are watching this. So thank you for your time from a patient perspective, and I hope it will generate some conversation as we go through the morning. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.